introduction. Prof.
Thank you. Thank you, Felicia, for inviting us, and thank you, the organizer, for giving us the chance. And we go very quickly. Yeah, after you seeing all the big toys and things like that, so this is where, if we have small toys, so this is why we do our research. So hopefully you get a little bit understanding from our perspective, from our lab, how do we deal with handling immune evasions in pancreatic cancer. So this is a project that actually have a lot of people hands in there. So it's not actually only myself. And so main of it, the acknowledgements will be actually the FRGS, which is the Fundamental Research Grant from the higher educations. And of course, we actually have to use multiple postgraduate grant that actually collect enough data to work on it. Yeah, that was also as old as when Felicia was still with us in IMU. And my master and PhD students have already graduated and is going to join me as postdoc. He's also did this part of the work. She's sitting here, yeah. So part of the work, I think maybe I can just pass the mic for her to talk. Yeah, she's there, thinking. So in case you need any more information, you can also talk to her about. So we actually need to accumulate quite a lot of grants to complete this study, and take us a while. But hopefully, it will be a meaningful sharing for today. So I think most of you will already know cancer is an uncontrolled disease, but the more important questions that we wanted to tackle from our group is, it is a heterogeneous problem. What it means by heterogeneous means that the cancers is not just one cell type that you're talking about. So you have a treatment that is going in. It's not just that treatment will kill out one cell and that's it, the end of the story. No. Unfortunately, we are dealing with the cells as a cancers that is multicellular, many problems, and means you have different things that's coming together. So that is the reasons why when we certainly, some drugs go in and kill off certain things, the certain cells die off, but some cells remain, and that's where you have drug resistance, immune resistance, and therapeutic failure. So just now Prof will show you how they do on chemo resistance, so that is one potential way to look at it. But for our group, we realized that pancreatic cancer is an important problem that we still haven't found solutions, because if you look at it, it is high mortality. It's most 1% patients, only 1% patient will probably survive in the next 5 years. And compared to other cancers, breast is probably only 21% of them will probably die in a year. And cervical cancer is about 27, but pancreatic cancer is about 93% of them probably won't survive the next year upon diagnosis. Yeah, this is where I say Chin main work is actually putting this diagram together, basically to study when, even as early as the days we were looking at this problem, we realized that immune cells actually play a lot of role. So you will realize that many different types of the immune cells, and also the tumor microenvironment is not one direction, it's multi-directions, and everybody was talking, the whole ecosystem is talking together before we can actually put it together. And one of the things that when you talk about immune cells and things like that, you can't run away talking about this immune cycle. So when we follow the immune cycles things and we put in the cancer cycles, so because this cancer immunity cycle is something that when we study immune systems, interaction with cancer, you can't run away from that. So basically what happened is, this is like an ecosystem. So cancer will need to show the antigen. So you have the antigen, cancer cells antigen release, then you have to present them, then you will be activated and your T cells will come in and infiltrate, eventually recognized by the cells, and eventually you will lead to the cancer killing. And this is the cycles of the cancers and immune cells were talking to each other. So, and that in every single of the step, you will see there are inhibition, there are also activation. There are things that are promoting it to happen. There are things who's actually stopping the story to go on and on. And you realize that the last step, which is step number 7, will usually have most of the problems that you already kind of know, like TP53 mutation, P10 loss, and these are the markers that we kind of already know. And that's where we most traditionally we look at cancer cells killing is the issue that we thought by addressing that, you will address all the cancer, anti-cancer related problem. But if you look at this particular cycle, you realize that it's not. You actually involve your immune cells at the very beginning, the way the T cells are presenting to it, it also playing a role. So it's not just about killing the cancer at the end of the day. So that leads us to, like Prof. Gom just now mentioned, why our group is always interested to look at new compound, new ways of killing the cancer, because we realize that every single molecule, being a pharmacist, I always believe that it's just we haven't know what the molecule can do. So every single molecule could potentially be useful in terms of at any junction of the cycle can be actually eliminating the cancer. Okay? So we always wanted to look for new targeted cancer therapy. To do that, being a small university, as you mentioned, we don't have a lot of resources, we don't have access to big biobank. I wish I have talked to Prof before. Then we will probably solve our problem in biobank in the old days. But this was like at least 5-6 years ago, before we even know where do we find the pancreatic cancer biobank. That was the first question we were asking. So we've been knocking doors, asking everybody, can you give us access of your sequencing and da da da. At the end of the day, we can't. Nobody gives us anything. So in the end, okay, luckily one thing is there are a lot of public domain that we can actually tap into. So two of the data sets that we were looking on, one is Pakai AU, which is from Australia. The other one is TCGA pancreatic cancer. So actually Felicia was helping a lot in this as well in the past. She probably won't remember because it's taking her a while to go. So when we were pulling out all the pancreatic cancer patients and then we do quite a lot of analysis, we realized that one phenomenon that we eventually able to divide to understand patients with high survival and low survival, better prognosis, sorry, in this case overall survival and progression-free survival, if I need to understand what population of patients have better survival, and eventually down to one particular activity, which is the cytotoxic T cell activity. So what we found from this part is we realized that if the patients have a high cytotoxic T cell activity, it seems to have better prognosis compared to those with low cytotoxic T cell. This is from the public available cohort. When we go a little bit deeper, we're trying to profile, remember the 7 steps that I showed you, the cancer immunity cycle, and we pull out all the gene signatures of every single step of the cycle, and we realize that at the end of the day, only the step number 7 actually has the most important role when coming to this whole high and low prognosis. So that zooms us into the number step 7, which is the killing of the cell, is actually having the main role. Although theoretically speaking, we look at the cancer immunity cycle, step 1, 2, 3, 4, 5, 6, 7 is playing a role, but step number 7, which is the one who is responsible to the killing of the cells by the T cell, is actually related to the step number 7. So again, high cytotoxic T cell activity is probably the reasons the cancers can be eliminated. So when we submitted the paper, the reviewer asked us, what about gender, what about age of diagnosis, would there be actually significant reasons? But when we pull out the analysis, we realize that all of this is not playing a significant role, which means it doesn't matter whether you're male or female, what age you're being diagnosed, you have no direct correlations on the activity of the cytotoxic T cell activity. So what we did was, as usual, because we have the gene signature, so we look at what are the commonly upregulated gene signature and also commonly downregulated gene signatures from these 2 data sets. So we have the pool of the 15 and 52. And what we did was we put them into major signaling pathway that we can foresee. And end up the 3 major one we found is TWIS, HDK5, and then EMOS signal. And what we did, the next thing is we now know the pathway responsible for high and low cytotoxic T cell activity would likely be reasons why pancreatic cancer have better or worse prognosis. We put all these gene signatures into this connectivity map analysis, which is actually a program by the Broad Institutes. And this program helped us to map all the genes to the known drug, FDA available drugs, because we are looking for new treatment. And when we map all the genes inside, you realize that consistently we see HDAC inhibitor is the one pop up in the list. So that means that HDAC inhibitor could potentially be the drugs that we can use, because just now you're saying that HDAC signaling was shown, and now again they were telling you the HDAC inhibitor is likely to be the drug you can use it to reverse the issue. So to do that, we need an experimental model to prove our concept, because until this particular junction, it's all bioinformatics. So we pull out all the data from PCGA, from Pakai AU dataset, we do all the bioinformatics analysis, and that's why we start to develop our own cell. So what happened is, I was telling you the cytotoxic T cell is the possible reasons why it is causing the bad survivors and stuff like that. So we use our pancreatic cancer cells, we challenge them with cytotoxic T cell until the cytotoxic T cells started to gain resistance to the cytotoxic T cell killing. So we have a CTL resistant cell line generated, and after that, what we did was we do a lot of screenings of the compound to test what are the compounds that are actually able to kill off the cytotoxic T cell resistant. So this is how it looks like, and we try with different doses of the cytotoxic T cell. Eventually, we optimize it at the 8:1. That means the number of the cytotoxic T cell with the number of cells, and that's ratio, and that will wipe off most of the cancer. But the cells that is survives, we will continue to grow them, and then we continue to kill them with cytotoxic T cell until the junctions where you see at the microscopically no cells are killing already after multiple rounds of the cytotoxic T cell. So these cells become resistant to cytotoxic T cell attack. So then once you develop the model, remember HDAC inhibitor was the one that we are interested. But if those of you who are in clinical pharmacy or pharmacy related, you will know there are many HDAC inhibitors, and each and every one of them have a different preference of different isoform of HDAC. So that come back to another question, which one is the one that we're supposed to use? So what we did was we just basically put all of them inside. And we put all of them inside, and then we see whether did there a difference in terms of mechanism, because each of them have a different structures as well. So what happened is the cytotoxic T cell, if you put the HDAC inhibitor, you will supposed to, let's say if they're not sensitive to HDAC inhibitor, they will continue to survive. So you will see them on the right hand side of the curve. Okay? But you will realize that some of the drugs able to shift the curve to the left, which means that the moment we add the HDAC inhibitor into the cytotoxic T cell resistant cancer, they started to die off because they already resist to cytotoxic T cell. So by the time I give them more cytotoxic T cell, they will still die. They won't die as well. They won't die, and because of the HDAC inhibitor, now the cytotoxic T cell can kill off the cancer. That's why it shifts the dose response curve towards the left hand side. Okay, and of course the left side is the control where the naive pancreatic cancer cells, let's say if I just put them in cytotoxic T cell, because they are still respond to cytotoxic T cell, but it's just that some of the populations that survive is the one that eventually will develop cytotoxic T cell resistance. Okay, so with that we've already realized that some of the compounds is good, but again it doesn't give us the answers of which one is the better one. Of course, in the dose response, we can profile that some of the drug actually works better, some of the drugs doesn't work well, but it's not good enough. So what we did was, because this questions was raised actually by the reviewer. So in a very, very short time, what we need to do is, we need to confirm why the HDAC inhibitor was different. Okay, so the easiest way we were thinking to do is, because they are structurally different, so we will actually look at their structure. One thing's good about this Swiss Predicts software was they will be able to use 2D, which means structural, to help us to map available data in the market when we use that to actually correlate back the target. So you realize that girinostat, which is one of the HDAC inhibitor, their target range is not the same as the vorinostat and trichostatin. Vorinostat and trichostatin are the one that actually not too active, and that's why the givinoset, desinostat is the one that is active, relatively speaking, among the HDAC inhibitor. So based on this particular analysis, immediately we can actually tell every single HDAC inhibitors are not the same. And it's also because of the structures, and we kind of know that each and every one of them may have a different target they can go. So to drill a little bit deeper, what happened is when we compare, givinoset, desinostat is the one that actually can reverse the cytotoxic T cell resistance when we add cytotoxic T cell into the pancreatic cancer. But vorinostat and trichostatin A, they are also HDAC inhibitor, but they can't actually reverse the cytotoxic T cell that much. So among even the HDAC inhibitor as a class, we also realize some of them work better, some of them don't work better in this cytotoxic T cell resistance. And givinoset, desinostat is the one that is work very well. The red one, which is vorinostat and trichostatins, are not doing so well. So when we profile them again, all of them will hit HDAC 1, 2, 3, 4, 5, 6, 7, 8, 9. That's why I eliminated those targets, because this 9 target is the one that actually been targeted by givinoset, desinostat, also vorinostat and trichostatin, which means they're probably not the answers to tell you whether how it works. So we zoom into what is difference compared to this group. We realize that this NOS1 and HDR1B and 1D is probably the reasons for it active, which is the givinoset and desinostat. But these markers, the bunch of them here, vorinostat and trichostatin targeted, is probably the reasons why the drugs doesn't work very well. Okay. So as a summary, we started from pancreatic cancer data set. From there, we understand that high cytotoxic T cell and low cytotoxic T cell is the reasons pancreatic cancer get better or worse prognosis. And from there, this gene signature help us to understand there is a potential drug that we can actually prioritize for, let's say you want to go for precision medicine. But this will not be enough because it's bioinformatics. You need wet lab for validation. So what we did was we developed the model, which is the cytotoxic T cell resistant pancreatic cancer model. And of course, we use high throughput screening methods to screen. And we realized eventually both information finding that we got, we mapped them together. HDAC inhibitor is the common answers that we found. And from there, we further validate them by putting back HDAC inhibitor into the cytotoxic T cell, and then eventually we realized that HDAC inhibitor could actually restore the pancreatic cancer back to the cytotoxic T cell sensitivity. So which means the next step we wanted to do is to validate whether by adding HDAC inhibitor, would the cytotoxic T cell resistance can be reversed, and hopefully pancreatic cancer, which is a cancer that is very deadly and don't give you most of the signals at the very beginning, probably is something to do with immune system, and that's why immune evasion is the biggest problem when it comes to pancreatic cancer. So the chain of thought for this is we can use molecular methods. Of course, this study takes us a while to complete. Nowadays, we have more sophisticated sequencing machines and tools. Prof Gorside have a lot of Chang'e tools, toys that we can play. So step like this actually will be faster and more efficient if we repeat this whole step study together. And of course, bioinformatics nowadays can do even better analysis, more truncated, more sophisticated. So there are more things for us to play, and we are happy to discuss more collaboration. So alone, we can't do much, okay? Together we can achieve more. So I have to really thank all my collaborators, the students, and also my postdoc, and that is coming. Yeah, nowadays only I got one postdoc, so after 11 years of trying to do, yeah. So funding is limited, so we really have to work together to work on this important aspect. With that, thank you very much. I think